So anybody who is actually a Morpheus user already? Very good. Anybody Facetite user already? Anybody who wish to go into and become a Facetite user? Very good, very good, very good. So, so I was fascinated by aesthetic medicine since I was like fourth year medical student, but I didn't want to do aesthetic medicine. You know, I wanted to do congenital heart disease. So these little, you know, boys and girls born with holes in the hearts, etc. So, you know, I saw and did the first national audit for, you know, kind of like the timing of the surgery in Syria, where I come from, Damascus University, for my MD degree, and we were, you know, off the charts. You know, there was somebody on the database who had their fallow tetralogy repair, so at 52-year-old. So they have lived 52 years in cyanosis, you know. So this is a procedure that done within the first year of life in the you know, advanced world. So globally, out of 8 billion inhabitants on this planet, we have around 2 billion, so 25%, who have access to emergency laparotomy. So, you know, like if somebody is dying, you want somebody to open their abdomen to save their life. Only 1 in 4 of Homo sapiens have that. So, you know, almost like similar incidence to the chimpanzees at the moment, because 1/4 of the chimpanzees are having a great access in, you know, reserve and in zoos. So we, as Homo sapiens and our relatives, the primates, have similar healthcare access. So you can imagine that Facetite will represent maybe 1 in 1,000, and you are 1 of 1,000,000 elitists who are concerned about, you know, something related to facial aesthetics. And why a congenital heart surgeon become, you know, kind of like the only UK professor of facial aesthetics, I don't know. You know, this is how the journey, and it's made by taking risks, by thinking, by asking questions. So when I came and I became a senior house officer in cardiac surgery, Bristol Royal Infirmary Children's Hospital scandal happened, and there was like a lot of noise about congenital heart, you know, surgery training in this country, and they closed the training program. So my mentor said, Ali, you know, you like kids, you like congenital anomalies, you should do plastic surgery because there are lots of deformities there. So I said, okay, you know, so I just thought I would jump in, but unfortunately to come from Syria and want to be a plastic surgeon in the UK means you have to kind of win the Nobel Prize, because, you know, you guys graduate from Edinburgh, from Cambridge, from, you know, Oxford, and have no access to this academic skills. So I had to do like a couple of masters, a PhD, and a countless diplomas in order to just be allowed to go in and become plastic surgeon. As soon as I finished my PhD and successfully was admitted into a you know, plastic surgery program, the UK started to face the important question: who should inject Botox and fillers? So there was around 200 hairdressers in the UK who is injecting Botox and fillers. And, you know, the government asked the question, okay, is that okay? You know, until now, we haven't answered that question, by the way. So, and then my boss, very beautiful, you know, plastic surgeon who like loathes aesthetics and private practice. He's a burn surgeon. He said, Ali, you have enough letters after your number, sorry, after your name. So you have to make the UK's and the world's first university program in facial aesthetics. So what is facial aesthetics? You know, I'm here to learn about congenital deformities, and I have to kind of, you know, now go and become a hairdresser after all these letters. So I took aesthetics, you know, extremely like for granted. I thought that this is something that, you know, you do in spas and stuff like that. But somehow I have to follow what the boss says. So he flew me around the world, and I get to see people who do injectables around the world, and invited them in. We created Queen Mary University of London Master, and I'm very grateful. I see some of you who have graduated from that program. And as I started now learning about reconstructive surgery and facial deformities, I was shocked. I was shocked, like, why? Like, we would have a kid coming with a facial deformity. Okay, they have a big hole in their face. We close the hole, and then they can breathe, they can eat, they can drink, but that's it. And we are like tapping ourselves on the shoulder saying, we have done a good job. This little one become like a teenager. He cannot have a girlfriend, or she cannot have a boyfriend. She doesn't have confidence. They need to go like for a lifelong, psychological rehabilitation. And we have not really saved them. Yes, we have saved their life, but there is much, much more to life than just closing a cleft or sorting out a swallowing problem. I have never ever in my life received compliments. I was always like the kind of like short one in the class. I was not very popular because I was a good student, and I was not good with girls, and I never get compliments except from my teachers. But in the last 6 months, I had like 1 million compliments for 1 inch of hair transplantation. Like, I am like what's going on? Like I lost a few hundred hairs from my hairline. And then as a joke between me and my student who does hair transplantation, he kind of like, fooled me into doing my hairline. I was not bothered with it. I looked in the mirror and I saw Ali. Now I look at the mirror, I see like slightly younger Ali, yeah? But my wife started to treat me differently. Like, I thought she's my best friend. So facial aesthetics is extremely important, and it is not trivial, and it is extremely serious and rewarding. Sadly, maybe very, very few people have access to it. Okay, statistically, I am the only professor of facial aesthetics, but maybe in 10 years there will be 1,000 professors of facial aesthetics in the UK. And for you to be here, you are motivated. They haven't paid you. It's an expensive machine. Neil has, talked me into cryolipolysis, and I donated my machine that I bought through him to one of my students, because I actually was one in 30,000 to have, hyperplasia, kind of paradoxical. So I was the first patient to be treated by the machine, and I lost faith in it. But the other machine, that I got from Neil, the radio frequency platform, and also the third machine that I get from Neil, which was the multi-platform one with the IPL, etc., for my therapist, really has moved me from a very small, kind of like rabbit hole to an international practice. So I grew something like 40,000% from my first month and now in 5 years. And that's because of my commitment to understand what is that I want to achieve. When somebody comes to me and say, I don't like this line, I listen carefully, I understand their complaint, I understand what they are trying, to achieve, what is their pain, but then I take over as a medical care practitioner, as a holistic, medical practitioner, to then evaluate their aging from the surface to the bone, from the hairline to the collarbone, and if necessary, to the toenails. So this is a very serious extension of medicine. It is not trivial, and we must approach it with the maximum commitment, rigor to like some of the elements that Neil has mentioned, evidence, ethics, and kind of enlightenment by research. So I call this talk the radiofrequency medicine, because now people talk about kind of like oncology medicine or gynecology, or and then we talk about aesthetic medicine. I think radiofrequency is so vast and so variable in its connotation that it is worth to be called radiofrequency medicine. So just a few days ago, I launched in the UK another, I launched the Morpheus, by the way, he forgotten about it, you know, so I was not the most successful in PR, I didn't understand PR then, but I launched the Morpheus in the UK, and I was the first plastic surgeon to engage with Facetite. At the time, you know, kind of people thought that I'm, you know, foolish, because within like 1 hour, I can make a mini facelift and I can have better results than what I can achieve with a technology. But, you know, those people did not understand something very important called patient's autonomy. You know, the patients did not want a scar, and they are very happy with partial improvement. These are my disclosures, proudly with InMode. And my job here today is to try, and if you are to engage with this device, to avoid you having to worry about these two. That's it. Yeah? Because this machine works in 73%. So I had to refund some of the people who thought not sure, and I had to kind of like compensate for some of the people who said not worth it. And that learning curve, I want you to avoid it. Yeah? So it's very important we collect patient-reported outcome measure and understand nothing work 100%. And sadly, these patients did not receive somebody who have received this lecture. You know, they have seen a practitioner who did not understand the mechanism of action, did not understand the anatomy, did not understand the limitation, did not choose the patient correctly. Because otherwise, you know, this 73% would have been 100%. So it's very important that we discuss the anatomy a little bit. I have studied anatomy until it came out of my ears. And I thought that in the last 5 years, I evolved from mini facelift to SMAS plication to SMAS imbrication to started to kind of like go slightly in the deep plane to kind of full deep plane to full deep neck. And I thought very proudly, as you know, one of 5 surgeons who do kind of like subplatysmal surgery in the UK, that I have done it. I have finished. You know, I know it all. I just need to focus on the business now. And then, unfortunately, only in June 2022, we really understand what is the jowl. You know, we have been doing anatomy since Galen, but only this paper finally put a definitive understanding of the human jowl. Any of you who is not familiar with this paper don't understand anything about the jowl, as I did not understand anything about it. And, you know, the jowl has been with us since it was coined by, you know, the greatest kind of writer of modern time, and at least the play, one of my favorite teachers, William Shakespeare, like in this beautiful play when, you know, in Act 3, Scene 2, you know, Demetrius, the great Demetrius, you know, we have a Demetrius in the family, said, cheek by jowl. So the jowl is the same as the cheek or the mandible. It's a synonym of these words. However, in the last like 100 years, we have like a kind of consensus in medicine to describe the area that is not favorable as a jowl and the area that is favorable as a cheek. But to then understand what it is very, very important, because if you don't understand it, believe me, I've done like over 100 Facetites, and every time I was doing it without this paper insights, there was like an element of my practice that is based on, oh God, please, like don't let me down. You know, it's relying on metaphysical space there. So suddenly now I cut the umbilical cord of my reliance on God for the Facetite procedure. I have so many things that I rely on him in. So we need to kind of come away from metaphysics and wishful thinking to actually seeing things and doing them correctly. So we didn't know, for example, when we have a basal cell carcinoma, I don't know if some of you are familiar with the term, some might not. So this is like a very benign skin cancer. So we didn't know how much we need to take of healthy skin around it until we have conclusive evidence that if you take 3 millimeter margin, you get around 85% clearance. If you take 4 millimeter margin, you get 96% clearance. So that insight is very important in aesthetic medicine too. And when you are able to work with certainty, you will greatly increase the satisfaction of your patients and greatly reduce the risk. Following me so far?
Yeah.
Great. So, look how much confusion, like since the first description of what a jowl mechanism of action, is. I mean, I can, easily send Neil the PDF, and he will share it with you. Don't get distracted. Just focus with my teaching, because I stayed until 3 a.m. to try and find all the jokes for you to understand this. So you have to reward me by your attention. Don't worry, I will send you all the paper, and then you can spend another 6 hours dissecting it. It takes a lot of time to understand this paper, but I'm trying to. So the jowl mechanism of action was thought to be a dam. That the jowl is actually a pool, a collected tissue of fat, skin, lax platysma that is stopping here because of a dam. And that dam is celebrated until now by the majority of facelift surgeon, and it's a kind of like a false god. Like there are true gods and there are false gods apparently. But it's a worshipped false god, because until June 2022, we thought that this is a osteocutaneous ligament, i.e. this is like a connective tissue that goes all the way from the bone to the skin or to the dermis. That is not true. But we only know that for the last 3 months. So what it is, initially they thought, it is like something at the, at the anterior border of the mandible. Then we have the jowl behind it, and then people thought, no, this is what you are seeing is the anterior fibers of the depressor anglioris, and what is we call the mandibular ligament is a very strong and sturdy something that is like several millimeter from the dow. And this is like actually a peer-reviewed article and a twint. So, and then after that, this, that, the other dimensions. So you might learn from this insight that sometimes even Homer errs. That you might get evidence and you might see that this is actually described in the literature, but you still have to have a healthy skepticism and try to counsel your patients and prepare them for the unknown. Because even though there are like 6 papers describing the jowl anatomically, none of them was able to understand it, and not because the surgeons or the anatomists were flawed, but because they didn't have electron microscope to look very carefully into the dissection, and they used kind of like formaldehyde candidates, which has been like lying face down on the anatomical lab, etc. So there is limitation of our knowledge acquisition. So it's very important for the Morpheus or Facetite, for it to work, it is very important for you to guide the tissue contraction in the correct way, and to understand where you can go like crazy. Yeah, I mean, like Neil will tell you, put 400 pulses in a face. Sometimes I put 2,000 pulses in the face. Yeah, so, I can be really aggressive and very gentle as well. The patient doesn't have significant downtime because of my understanding of the anatomy and some of the basic principles of radiofrequency medicine. So when you understand the anatomy, you will be able to focus on the areas that you need to focus on, and then ignore the areas that are not important. And I will tell you that my practice of Facetite has been based on previous colleagues who have more experience. But then as I grew with independent experience, I started to adapt anatomy into my approach, leaving the habits of my seniors. And I want you to kind of understand that, because that will help you not only here, but also in your injectables too. So it's very important to understand, the relationship of the labiomandibular crease, or as known as the marionette lines, the lower lip muscles, the marginal mandibular nerve, the buccal fat, the masseter muscle, and the submandibular gland into this area. Because the patient comes to you, they have signs of aging, and you need to understand which is contributing to what, and where you can use Nefertiti lift to improve things, and when Botox is not enough, and when Morpheus is good, and when you need a surgeon. So all these things are related to this very small, kind of 4 by 4 centimeter area that I will try to whiz through to it. So the conclusion that I want you to understand is that the key point is from the midline. If we imagine a midline, so if we take 6 centimeter from the midline, we are at the end of the insertion, the bony insertion of the platysma muscle. And that is a key point. Now, the jowl is the distance between that point and 4 centimeter in front of it. Yeah? And why is that? I will explain to you. So, this very interesting, what was perceived as a ligament is not ligament. It is just a condensation of the insertion of the platysma passing under the medial border of the depressor anglioris. The point is that this is happening only at a muscle and dermis level. There is nothing deep from the marionette line and forward. Accordingly, this area is extremely tethered. The dermis is extremely tethered to the muscle, and then the marginal mandibular nerve cannot be dissected by hydrodissection. So here the marginal mandibular nerve will come and supply the dow and the mentalis and part of the platysma. So if we injure it in front of the marionette line or before of the marionette line, we will end up with a checkpoint smile. Yeah? So a checkpoint smile is a lesion of the marginal mandibular nerve anywhere from the parotid to the mentalis muscle. But from this point onwards, the muscle is severely adherent to the dermis. That if we do like tumescent fluid, we cannot separate the two. However, from the jowl, from the beginning of the perceived jowl, or from the labiomandibular groove and backwards, there is in the most of the population, there is a huge redundancy of level 2, dermis, subcutaneous fat, SMAS, deep fat, periosteum, you know that, kind of injectable guide. So here between level 2 and level 3, because when we are very young, we have a lot of elastin and collagen. We can open our mouth maximum and then close our mouth, and that stretching, which is around 4 centimeter of the tissue, is totally accommodated without need for tissue redundancy. Yeah? But unfortunately, as we lose elastin and collagen, that 4 centimeter has to be accommodated somewhere. And that's what the jowl is. It's just like the redundancy of the tissue having been stretched and depleted of collagen and elastin. And it is only happening at the dermis attachment to the muscle. So it is above the SMAS. So from here, we can do hydrodissection, and we can separate what we are going to treat, which is this retaining ligament plus the dermis, from the SMAS, which is here the platysma, that is protecting also the nerve. But sometimes the SMAS is so flimsy. Sometimes, the platysma is so thin. So don't think that just by a hydrodissection and separating these dermis and from the platysma, and you are in the right kind of like playing with your Facetite tip that you are safe, because sometimes the floor is very flimsy. So this is 70 degrees Celsius probe that can transmit through a very flimsy platysma, and if you are in the territory of the nerve, you might have lesion even if you have taken all the precautions. So the patient has to know about that. Yeah? So very interesting is to understand that there is no ligament deep. It is only the attachment from the platysma and the depressor labii inferioris and the dow. So they are in this order: platysma, dow, and depressor labii inferioris, and they can reach up to 6 centimeter from the midline of the mandible. So here, in this area, the nerve cannot come and penetrate. It has to go like in this little tunnel between the masseter and these muscle attachment, and then the nerve is a very, very intimate to these muscles, but they are behind them all. So this distance here is almost fixed. It's slightly smaller in ladies and people with extreme micrognathia, but it is like around 6 centimeter, and that's very important for you to know if you are to engage with Facetite. So the rest is interesting, that the nerve here is actually more vulnerable under the mandible with this procedure than it is with above the mandible, because often we really worry about this area, and then sometimes we can like go and treat the neck under the mandible here, and that's where we might injure it. So it's very wise to kind of like think that is actually often we can injure the nerve much earlier than we think it is vulnerable, because here it's really protected with the platysma. You could see here that the platysma is quite thick and it's protecting it. So, but usually when the patient presents with the lesion, we don't know where we manage to kind of like injure. So that's why you will see today slightly different variation from the typical PowerPoints that you might see about the Facetite procedure. So I will share with you my approach, which guarantees the safety and reduce significantly the incidence of damaging the marginal mandibular nerve. So in summary, the mandible is our key, for me, after moving from congenital heart disease to going into the kind of facial aesthetics, to going into the non-surgical and surgical. So my passion now is just like a 20 centimeter distance between the zygoma and the clavicle, and this is the key for the aesthetics of the face. So you should learn this slide kind of as well as you can. But what we will be treating today is the jowl, and then you need to understand that kind of like the attachment of the platysma is really consistent, is around 55 millimeter in female and around 62 millimeter in male from the midline, so around 6 centimeter. So from there, you need to understand that there is a very dense 3 kind of muscles attached to the mandible, and then the nerve will come from that tiny little space to go behind them. So there need to be, in your plan, understanding of where is the jowl, because if you don't treat the jowl, it will not shrink. And if you treat the jowl blindly, you will damage the nerve. So it's very important you understand that point, that we have like a little risky area here, and then this area is around 6 centimeter, and the jowl is centralized around it. So it has a little bit of extension below the mandibular, because by definition, the jowl is the kind of the result of the extension happening of Homo sapiens opening their mouth at the maximum. Yeah. So we have our modulus, and we have the mandibular border. And as we do that many times, then we have a little bit of laxity. There is no herniation of fat. There is no hypertrophy of fat. There is no fat. There is only redundant, kind of like cutaneous tissue, and also elongation of the vertical septa between the dermis and the platysma. And the platysma here is actually very, very tethered, at the middle of the jowl. So historically, we thought that we have to do a deep plane face lift in order to kind of like tighten the lax platysma, and that Facetite might not work 100% because it doesn't address the deep tissue laxity. It only addresses the skin laxity. This paper confirmed that Facetite is actually as good as surgery for treating jowl if you do it properly. Yeah, because the deep plane facelift works not because it actually moves the jowl. It's just because of the utilization of the platysma above the tethering point. And you can imagine that when this section is pulled, some improvement will happen on the skin because the platysma is attached to the skin. So it is indirect rather than direct improvement with even the most aggressive of facelifts. So the best way is to try and increase the elasticity and the collagen content of that area that has been damaged by the ears. And the nerve will come with a variable relationship. It cannot go into the masseter. So it comes from the parotid, which is behind the masseter, and then unfortunately there is like a huge masticatory like muscle in front of it. He has to do a detour. So he just dives below to avoid the masseter, and then as soon as he has a chance to come back to its target muscles, it will do that. So by understanding where is the masseter, and when the patient bites, you can almost imagine the course of the nerve, and then try to plan your safety zone, not based on just like 2 centimeters from here, 3 centimeters of them, with actual anatomical accuracy. Okay, so from now, I want you to stop recording your videos and, don't take photos. That was very important for you to understand the anatomy, and we will just go and whiz through what we need to talk about in relation of the nitty-gritty of this procedure. So the reason why I have 16 machines now and over 1 million pound in lease for machines, even though like my procedure, kind of has been celebrated in Tatler without me paying them. I'm paying them over 8,000 pounds for 2023, but for that year I didn't pay them. So they are they like labeled me as best for total face refresh, because I believe that I can be a mediocre surgeon and do 70% good job on the upper lid, lower lid, face, neck, nose, and then have much better outcome than the surgeon who do 100% on any of them and ignoring the rest. Yeah, so Christopher Columbus discovered America in 1592 or 1492. I discovered this like conclusion in my second year of private practice, that I don't treat lines. The patients come, I treat the hairline to the clavicle, epidermis to the bone. If I do 50% job in everything, it will be much, much better outcome than if you do 100% on any individual thing. Yeah. So, but still, even with my excellent approach, I do this procedure maybe 3-4 times a month. I can live on that, and I can, stay and have a holiday for 26 days in the month, and then just do these 4 procedures because they pay very well. I will not tell you because the price is going up in the new clinic. But I'm much cheaper than the Fifth Avenue in New York, so I am trying to establish a facial deformity center in Damascus, Syria, against the American sanctions. And unfortunately, that needs a lot of money. So I have to treat a lot of wrinkles. And many of the patients come to me and say, Ali, we know you're a surgeon. We don't want surgery. And what shall I do? Send them to Sophie? Like, like it's not a good idea. Like I have to. I know you would look after them even better than I can. So, but then, I have to do something. They say, oh, like, what can you do for me? Then I thought, okay, what can we do? Then I start looking at these devices, and every day you have another device, and then, we have to kind of like think about evidence, think about machines, and, there is a questions about every machine coming, is it working, is it not? It's really, really stressful. So my mentor, Sam Hamra, told me, with his like key 3 papers that, with a scalpel, you can do like everything to a very, very high end. But believe me, my last total face refresh, very beautiful colleague, a professor of cardiology, she is now week 4 and she still have some kind of periorbital swelling, after the surgery. And I'm very kind of annoyed about that. I promised her 3 weeks you can go back to outpatient clinic. I failed her. I didn't expect that periorbital edema will last like, sometimes it can last like 2 months, 3 months. Even with Facetite, edema is very difficult to understand because like I am short and this gentleman is tall, my lymphatic drainage can be maybe double this lady, and you can have like triple our, so it's a normally distributed phenomena. We cannot like put a finger and a number on everything. So I think of my treatment spectrum as injectables, and energy-based devices, and then surgery. And you can do a lot of things with a single modality. This is like the great one and only Maurizio De Maio, kind of doing this transformation just with gel, just with hyaluronic acid. Like the jowl is gone, the kind of malar ligament is gone, the hollows. It's amazing how to kind of achieve things with a single treatment. But with surgery, you have like a possibility of doing all this transformation and then having them for like 5-6 years. However, there is now a very important new emergence that is bridging the gap between the injectables and the surgery, which is the medical physicists and the engineers. They are thinking about anatomy, they are thinking about mechanisms of action, and they are creating amazing solutions. And definitely, that made me think about, kind of like a traffic light system where the green is the injectables, the red is surgery, and then the amber would be the energy-based devices. And this is why InMode has like grown so much in the last 2 decades, because they managed to understand this need, they managed to understand that gap, and they have been investing heavily in addressing that gap. If you are not a plastic surgeon or a maxillofacial surgeon or an ENT surgeon, you have to have a friend who is one. Eventually you will need to refer like the patient for a surgical intervention. It is not necessary for a long time to actually refer to us. And I'm telling you, I have completed my portfolio. I can do everything in the face now. It costed me a lot of time and money traveling around the world and seeing everyone doing everything. But it is too much risk, too much downtime. We are in central London. Everybody is executive. They need to go to the dinner tonight. To Ali, I am going to the opera. I don't want any bruise, for God's sake. I do 100 injection for my total face and neck botulinum toxin. 100 injection. If I have one error, it's a good incidence, 1% bruise. This is the stress that our patients put us in, So InMode is able to present with us with solutions, that if we kind of manage, initially I struggled with Morpheus because I didn't, for example, understand how to anesthetize the patient. I didn't understand how to block the patient. We didn't have the understanding of the best way to put kind of the local anesthesia. We started buying, 30% lidocaine from China and trying to break the law and, kind of smuggle it in suitcases. And totally unnecessary. We now understand that if we put 4% lidocaine, kind of like twice with some occlusion, we have a very comfortable patient. So sometimes the technology, does not let us down, but our limited knowledge and understanding does. So that's why it's very important to really understand what Neil has talked about, because that success, that 73%, kind of happy patients is actually real. So all this has been covered by Neil now, and the different awards. The entire radiofrequency medicine is based on one paper published in the 1960s. The whole radiofrequency medicine is based on that paper. And that paper says that a collagen molecule will start shrinking after 42 degrees. Why 42 degrees? Unfortunately, because fever does not give us a facelift. So otherwise we will all try to get the flu from each other, and within 3 seasons we were facelifted. So 42 degrees, the degree at which the collagen in the brain will start to morph, that's when the Homo sapiens kind of said, my protein coagulation will start at 42 degrees. We don't hear with a fever of 45 degrees, do we? Because the patient would have died. It could have reached that level, but the signaling pathways and the receptors and all these tiny little proteins that are working in our brain and our heart are far, far more vulnerable than collagen. Collagen is very sturdy protein. But after 42 degrees, it starts to shrink. And it shrinks like our very nice Wagyu beef steak. If you put it for 50 seconds on the pan, it will become medium rare. And if you measure it, it was 9 centimeter before, it is now 8.5 centimeter. If you put it for another 1 minute, it becomes medium. You measure it, it is 8 centimeter. You put it another minute until you reach 70 degree. After 70 degree, you burn it. You cannot eat it. It becomes rubbery and the tissue dies. And this is where the genius of InMode, that they got this paper and they put it in their electrodes. That the electrode is not allowed to go beyond 70 degrees, and they managed to even, in the second edition, to kind of stop it at 42. So we have a situation in which on the outside, where it matters for us to see damage, i.e. burn, the temperature can be controlled to stay physiological, 37 degrees. But we can deliver 70 degrees Celsius temperature on this side of the dermis, on the underside of the dermis, as long as we need until the outer level of the dermis start to kind of become hot enough to worry the machine. It switch the machine off and you cannot burn the patient. What happens sometimes that you might be in the wrong plane. Your probe is too superficial to kind of allow the communication between these two probes. So actually you make the burn before the machine switches itself off. So that's why it's very important for you to understand the anatomy and put the probe where they are. Unfortunately, this machine is not good news for surgeons because, a chimpanzee from the 25% who are being looked after in the zoos can actually operate it. You don't need a Homo sapiens to operate it. The learning curve that I had, the refunds that I have done, only related to simple human, virtue called ignorance. The blissful ignorance. When we are ignorant, we can just do action ignorantly. But when I started saying, no, I actually should do this with more insight than what I have learned on one nice trip to a beautiful European, kind of country, and I should make my own research and not just treat the patient with one A4 notes that I've done, you know, or a little video kind of that I got in a conference, that's when I started to get results, and that's the reason why I'm here to share with you. So between 40 to 70 is the key temperature to coagulate, you know, kind of protein and collagen, most importantly. But when we are in a fractional mode, we don't care. Because as you know, with CO2 laser, we are actually burning the tissue. Yeah? Historically, fully ablative. We destroy the entire skin tangentially. But with the Morpheus, the beauty of Morpheus is that, you know, the tip of the Morpheus at 60 joule is like almost, you are about, you know, kind of like half the distance between, Mercury and the sun. It's very hot. It's like over 300 degrees Celsius. So, but we need that. And we need it to kind of like create that destruction of the tissue, but microscopically. So that tiny little stimulation of the fibroblast and the myofibroblast will give us the contraction. So accordingly, in the jowl area, you have to go like 5 passes, you know, like you have to go 4 millimeters, 7 millimeter, 3 millimeter. It doesn't matter. We have a lot of redundancy, and you have to understand that, you know, the more you do it, the better the outcome. And I only learned that because of plastic surgeons. I have a plastic surgeon colleague who is like around 10 years older than me. When I announced, you know, that I'm very grateful to him because he's actually, you know, kind of enabled me to pay for the lease of the Morpheus. So when I announced that I am launching the Morpheus, he has had some research about it, and then he just came and said, Ali, I want the Morpheus. I don't know him, and he introduced himself. Oh, great honor. Why we don't do just a mini facelift for you? No, I don't want this car. Like he's a surgeon. So okay, fine, you know, this doesn't work. He said, I don't care. You know, like, why? Because he has a lot of redundancy. I didn't want to kind of treat him, give him pain, and then like tells me, oh, it didn't work. You know, too much redundancy. Through the COVID-19 pandemic, he religiously came every month and had a total of 17 Morpheus8. I will show you a picture of him after the 4th one. And he looks as if he had a facelift. But it's not 3. Yeah, it is not 3. You know, it is 17. So biology works. And the reason why it's not 3, because if you increase the parameters, then you will get downtime similar to the facelift. Yeah, and I've done that. I have like really taken the tissue to the maximum with Morpheus8. After the protocol that we usually teach, and you will saw me teaching you today, it's no point. It's no point because you lose the advantage of low downtime. You know, you start having, you know, kind of long edema, like, you know, the scabs takes 3 weeks to go away. There's no point. It's better to keep it as a very nice treatment, very gentle treatment, low downtime. The patient can go back to work the following day. But okay, tell them that, you know, we do 3, and if you're not happy, we can do 1 extra for free. But you have to do, I tell them, we have to do 2 per a decade of your life. Good formula. They like formula. Patients like formula. Somebody comes at 50, you need 10. You know, unfortunately, you're losing too much collagen. So they have a formula that they can respect. So we say, okay, we just do like 4 now. We get you back to your 30s. And then after, you know, like we can do another like 3 or 4 next year. Yeah? So the beauty is that, you know, initially we had fractura, and it was like a needle without this beautiful silicone sheath, and it was beautiful machine. It was like really resurfacing and tightening, but the downtime was very long. And then InMode realized, well, you know, safety and downtime before results. So unfortunately, fractura is now discontinued. You can order it, you know, but you know, it has been replaced to reduce the downtime. The efficacy of Morpheus has been like with the pain reduced from its sister fractura, because we need the patient to be happy. We need them to kind of be industrious and go back to work, etc. And all these details, you know, like Neil can send it to you, like the specification of the different ones. But I have to tell you that I used body a lot, sometimes on the face, if the patient has a lot of aging signs, because I actually, like, you know, use my physical examination. So like if I do like that and I have like 7 millimeter between my two fingers, yeah, I just fold the skin on itself and then I treat at 7 millimeter with the 7 millimeter. No big deal. But I wouldn't treat perpendicularly because that will go to the bone. Yeah? So you can, these are just tools. Like you can imagine, as a plastic surgeon, I only have a scalpel and I can do everything with it. From the eye to the nose to the face, it is a tool and you can use it like everywhere there is a need to tighten the collagen. There is a machine similar to this with maybe like around 20 centimeter with only 5 needles that is used to ablate the liver metastasis, cancer. And this is the same mechanism. You just go there and it ablates the kind of cancerous cells in the liver precisely. Yeah? So we can use it anywhere we need tightening, we need, you know, and then you need to kind of look, if the patient say, oh, I have supraumbilical, you know, okay, just measure that, you know, squeeze it, look at the skin, see, okay, is it 1 millimeter that is enough? Okay, just give it hell with 1 millimeter. If you go 2 millimeter, you are in the fat, it's not going to give you results. Yeah, so you need to really think of it as a tool. It's not a robot, it's a tool. So we have the body and we have the very beautiful prime. I'm going to use it today. The patient has malar edema without fillers, but very interesting malar edema. So I hope that Neil have got us some nice, you know, 12 pin primes, because I will show you, you know, how the Beverly Hills, you know, kind of oculoplastics charge $5,000 for a 20 minutes procedure. So for malar edema, beautiful outcome with Morpheus for that. Morpheus8 is a working horse, is 24 pins. And then we have also the resurface. The patients also will benefit from a little bit of resurface. It's like a very gentle CO2 laser. It's like only 600 micron, around, you know, 5% density. So it's a, you can make it as a fully ablative if you made 10 passes, you know. Again, it's a tool. Decline. Sorry. Where's my phone? If my phone there, just decline it, please. Yeah. Good. And you could see here, you know, with the video that this actually works. You know, if you look here, how, you know, the sparkles are there and the tissue is being destroyed. You know, this is not like a fiction. And beautifully, we have now a technology that is allowing us to treat several layers in one burst. Yeah, it's called the burst. So it goes by 2 millimeter. Why? Because the ablative diameter zone is 2 millimeters. So there's no point going up 1 millimeter. So we need to really go 2 millimeter. So then we can go 7, 5, 3 or 6, 4, 2. And that is a very powerful 3-dimensional fractional radiofrequency microneedling. You could do it, you know, with the face one, but you have to do it manually, i.e., like you put as 4 millimeter, and then you do the pass, and then you change to 3 millimeter, you do the pass again, etc., etc. Now, very interestingly, it is extremely predictable to know how much ablation you will receive, and because it's like the relationship is with energy. I usually worry about the downtime. If the patient wants Morpheus in my practice, it means they don't want surgery. So With that, I stay around like the 30. So basically, I am around 12% ablation and around 1 millimeter coagulation. So I stack. I put triple stacking or double stacking to increase and reach almost similar outcome that I can have with energy of 60, with the patient still being able to tolerate an energy of 30. Does that make sense? And you could see that, and again, I encourage you to take aesthetic medicine seriously. You know, I have taken all sorts of, you know, catastrophic business decisions, but correct medical decisions when I went into the private practice. So for example, I invested on day one with the 3D camera and the skin analysis. So 30,000 pounds out of my bank account, I don't have a single patient. I maybe didn't use them before, you know, 3-4 months later. Yeah, but I invested in that because, you know, I cannot work as a cardiologist without a good Littmann stethoscope. So for me, I cannot rely only on the iPhone to take for before and after. I need data. I need to see exactly what's going on. And that helped me because many patients came and said, oh, you know, I had the treatment. I don't see anything changed. And then you look at the photos that they have taken. You know, one is in the kitchen with one light coming, and the other one is like, you know, with a dazzling light in the sun, you know, on the beach. You know, and they ask you to compare. So we need to have a standardized assessment. And then I just put them on the 3D camera and tell them exactly how many millimeter their jowl has reduced. And this is physics. It's not metaphysics. Part of it, God has been like involved in some of operations that I've done, but now, you know, I can give him a rest. So, you know, this is possible when you know the anatomy and when you know the energy levels and what you can do with it. You know, this is possible. This is possible with a little bit of filler. You know, there was like a little bit of chin augmentation there. You know, we cannot give all the credit for. So you can combine things and then you can have really nice results. And we all remember, you know, Judy Mary's with the beautiful combination of chemical peels, Morpheus8, some collagen stimulating fillers. You can have amazing transformation, you know, that is worthy to talk about on the public. You know, you could see here the amazing rejuvenation and improvement, you know, that Morpheus is able to do. You know, with the body too, you know, I really use it a lot after liposuction, you know, in combination with other devices. You could see here, you know, very interesting improvement, very difficult area to treat. Facetite and BodyTite is based on the concept that I told you, bipolar radiofrequency. So we have, as I mentioned, you know, a probe that is rising to up to 70 degrees Celsius, talking to a probe that is left on the surface that we can set it to switch the machine off when it reaches anything between 35 degree to 42 degree. So in areas where we have a lot of thick skin, I am very aggressive. I put 70, 42. In patients who have tiny, flimsy skin, I go extremely conservative because I know it's physics. If I give it 55 degree, the collagen is going to shrink. Yeah, but I don't want it to happen very quickly and very powerfully. So I then start using my culinary art, you know, ideas of, you know, how to cook the lamb, you know, etc. So the same thing I apply with collagen stimulation. And it's true, and it has been studied and validated in so many different ways. And that's why it's FDA cleared. You know, the FDA clearance happened with the second generation Facetite, BodyTite, when we were able to control the external temperature. The first device was not FDA cleared. So this is like a beautiful triumph of science. And you can see here, again, as I showed you with the Morpheus, this is not a hype. This is actual real-time tissue contraction. Yeah? So if we are to do this and leave the probe in one spot, then we will create huge deformity for the patient. Yeah, you will see me moving the probe all the time to kind of like stimulate collagen in a homogeneous way. You know, like when you are doing your kind of like morning, you know, oat porridge. You know, if you kind of put all the porridge on the water, you know, it will have clumps. You have to put them slowly, slowly, and keep simmering, so that you have that very nice, creamy, you know, texture. Similarly, here too. And this is level 1 evidence out of the 60 papers that Neil referred to. One of them is a randomized control trial on patients who are undergoing, you know, an abdominoplasty. So they actually tattooed them, and they did the, you know, body tight on them, and they showed conclusively that you have a statistically significant contraction compared to liposuction alone. Then we have the wonder device, the Accutite, which enables us now to take radiofrequency anywhere on the human skin. So you can, you know, I remember my first upper blepharoplasty or incisionless blepharoplasty. I did it actually with the Facetite, you know, in the upper lid, and I had great results, but it scared me for around, you know, kind of like couple of weeks, because, you know, like really it gave me a very sharp induration of the crease. I thought that I had a burn, but luckily it was not. It was just like collagen contraction. But now I can do this easily with the Accutite. You know, you don't need to have the big machine to treat very small areas around the face. Again, you know, Mulholland have done lower blepharoplasty tightening with the original body tight, you know, 2.3 millimeter when that came, and then we have the Facetite, and then we have the Accutite to work there. So it's very safe. It has been, you know, attempted with very big kind of tools for very delicate areas, you know, in the experienced hands. It's just a tool. Contraindications, you know, is exactly like what we like to do in aesthetic medicine. You know, it's very difficult to understand how the skin will respond with patients with connective tissue disorder. It's very difficult to understand how wound healing will happen in patients with autoimmune disease. It is very difficult to understand how a permanent filler or a permanent thread, or even, you know, polyl lactic acid thread will behave when we have like a Facetite, you know, going, you know, close to it. You can do, and I often do, combine surgical grade threads with this technology, but I start with this technology and then I use the thread after. So for you who are interested, for example, there is like the Elevate procedure where we can improve the cervicomental angle, and it's a very nice combination with Facetite. I will show you some examples. Very little number of tools needed. You need to have CQC for minor surgery and the local anesthesia to do this procedure. And, you know, like you can take picture if you want, but basically it's like doing microliposuction. You have to understand that if you have less than 1 centimeter of thickness of the tissue in your pinch, then it's better to use the Accutite. If you have more than 1 centimeter, it's safe to use the Facetite. Now, all these has going to be changed. You know, I will have to kind of like rewrite all these different zones, but more or less there are lots of wisdom in it, which is basically we can treat any areas that is not very close to a major motor nerve. So we will be able to treat the jowl, the area above the mandible. We will have to respect the, you know, the area of the marginal mandibular, and for that we have to do a lot of hydrodissection and go very superficial, which is fine. We can treat all the neck. We can treat the nasolabial folds, the lower lid. Also, we can treat, you know, the forehead in a zone that protects the supraorbital and supratrochlear, and also the frontal branch of the facial nerve. And it's really simple. It's like if you are an advanced injector, it's not really different from, you know, kind of using fillers. Is this a video? I don't know. So you could see that you have like a cannula of around 1 millimeter, and then you are sticking to the superficial fat compartment. You are just staying, you know, in that, trying to heat the vertical, you know, kind of retinacula as well as the dermis. And if you have like a little, you know, thermal sensor, you know, I have a tiny little 200-pound infrared camera that I put it on the iPhone, and you can have very nice pictures just to confirm that actually the tissue is heating to the right temperature. I am not using it for the last 2 years, but initially I was like, you know, oh, let me see. So it's not necessary because the dual sensory mechanism is guaranteeing you to have the results. So accordingly, you can really use the technology all around the face or around the body, and then you can complement it with the radio frequency, you know, microneedling, and just be aware of these. I have damaged many nerves in the last 5 years, many like less than 20, but I don't know how many. No big deal. They all recover, you know, as soon as maybe a week. But I had somebody like, you know, who didn't recover for 3 weeks. Then I had to Botox them. So now I actually promise the nerve injury to the patient. So this is how I, you know, kind of like prepare them. I tell them that in my full face Botox, I do the dows, so that you might not be able to be kind of like sad for 3 months. If this happen, I will check you the following day. If it is there, we will just give you Botox for both areas. By the time the Botox recovers, the nerve recovers. So I don't know how much time it will take to recover. Initially, I was waiting, and it's like, you know, the patient might have, you know, kind of like asymmetrical smile. There are lots of people who are born without, you know, depressor labii inferioris. So, you know, it's something that if you look at people, you'll have, you know, notice that around 2% of the population have a checkpoint smile. So if the patient know about it, if they know that it's not permanent, they are really easy about it. Entry points is very important, and I have to tell you that even though it's only 1 millimeter like entry with the needle, unfortunately I had a couple of patients who had developed, you know, post-inflammatory hyperpigmentation of the entry point, and one had, you know, in this entry point like a little bit of a keloid scar. So the risk is there. Any injury to the skin in patients who are genetically prone to have a scar can manifest itself in a scar, and you have to warn the patient of that and take every precaution. So I am super, you know, avert to the scars on the face and neck area, yeah, because if the patient don't mind the scar, I will do a mini facelift for them. They come to me to have this procedure because they don't like scars, so I cannot leave them with scars here. Vati, for example, goes into the labiomandibular ligament so that he cooks the jowl in retrospect from here. I cannot do that. You know, maybe his patients are all kind of old, rich Italian ladies, you know, like I have younger population and, you know, some Arabs, some kind of pigmented patients, so I cannot take that risk. So I go only with 3 entry points, and I treat the entire lower face and neck from it. And only if I need to go down to the lower neck that I have to then try to find a little mole or little imperfection in the skin to utilize it so that I don't create a new one. We will discuss that, you know, but for even these ones that develop these issues, you know, sometimes it can be man-made errors, because this is like, as I told you, 70 degrees Celsius probe. So when we are removing it out of the entry point, we can create a thermal burn. And when we are not gentle in going back and forth, we can create a friction burn. So sometimes we create these problems. So the technique of being gentle, of understanding the temperature, waiting a little bit until the probe cools down and then removing it is very, very rewarding. These are typical drawings we will draw on the patient. Now, swelling after post-operation, we don't have any reliable data on anything that can reduce it. It is going to be the only side effect of the patient. And for me, I just have like a level 1 evidence from ankle swelling, showing that, you know, those who had pressure into their ankles after ankle injury, the pressure did not make any difference, you know, after day 5. So I try to tell my patients to use their pressure garments in the first 5 days, because that there seems to be an evidence of reduction of the swelling. But after that, I tell them to use it just to mold the collagen, and they can use it nightly up to like 6 weeks. Why that? Because collagen only starts to be produced on day 21. So before day 21, we are only talking about swelling. After day 21, we are talking about the insight that we have from pressure garment in burn patients, which lead to reduction of the hypertrophic scars and a better aesthetic outcome of the burn. So the pressure garment has this dual function. From the first 3 weeks, it's helping to reduce the swelling. After 3 weeks, it helps to mold the kind of like the regularity of the new collagen. So these are not my patients, and you could see that immediately you can have results, because you have an immediate tissue contraction with a little bit of like, you know, reorganization of the fat tissue. So this is, you know, immediate results. And some of the patients, you know, will have that effect. You know, today's patient, maybe she will have a very nice definition because she's young and she has a very good quality skin, and she has like a little bit of adiposity, and she will have like an immediate improvement. Dr. Pagano, very great colleague and expert from Spain, originally Italian, he doesn't tumesce a lot. You know, he just gives the tissue a little bit of a anesthesia, but then he tumesces more at the marginal mandibular zone. For me, I usually put around 150 mils in the face, and that's like not too wet and not too dry, but we will discuss that within the workshop. And you could see that this jowl is now we know it is a skin and soft tissue redundancy. So an appropriate treatment is going to shrink it. When you have like a lot of redundancy, even with maximum energy, the patient will have, you know, kind of great improvement, but incomplete correction. So we have now, you know, collectively the KOLs around the world, we studied this phenomena. If you are familiar with the, like, you know, cervicomental angle and the jowl classification system, so there is a classification system, and the Facetite on average will drop the classification by 1.5 points. So if the patient is on 5, this is like, for example, the patient here is on 4. So then she will become 3 or 2.5. So that's the limitation of the, you know, device. It cannot shift people from 5 to 1. So you have to communicate that to the patient. Again, you know, 3 become 2. It doesn't deal with subplatysma problems. So a submandibular gland ptosis will continue to be the same because we are treating the skin above the platysma. So you have to make a correct diagnosis, and you have to tell the patients about it. So I have, in my early stages of facelift, made the mistake of not understanding properly what, you know, under platysma contribution to the facial aging. So I wouldn't notice the kind of submandibular gland, and the patient will be disappointed, you know, oh, look, I still have laxity, you know. So in a way, it's the only thing that the patient wants is to understand and to be informed. So if the patient have you know, deep structure problem, you have to point them to the patient. And it is it's a lasting procedure, because, you know, collagen, when it's in you, the half time of it is like 8 years. And the contraction is a kind of a mechanical contraction, and the patient will kind of age normally after that. However, if the patient has a very, very poor quality skin, you might not, you know, have the results that you want. So in a way, the quality of the skin, sun damage, you know, play a very important role in, you know, the outcome. And you have to warn the patient, you know, who has a poor quality skin. You tell them, maybe we have to work a little bit with collagen stimulating agents. Maybe we have to give you a little bit of collagen supplement during the time of recovery. You know, you have to do your best to improve the skin to respond. You know, Acutite, a great tool for working around the face. You know, you can have a little bit of, you know, improvement in the periorbital area. And of course, you know, like with the body, you can work anywhere there is a skin, and you can have really impressive shrinking up to 30% of the total surface area, especially combined with liposuction. And as you can see, it's like working with a filler cannula, but keeping an eye on the temperature. The patient doesn't have periorbital redundancy today, so we cannot show you these, but we will have a lot of time to discuss about Morpheus and the lower face, which is a good you know, outcome. So yeah, you can work on, you know, any area that there is a skin. You know, this is my patient only 4 years after a facelift done elsewhere, and she came and her budget has been exhausted. This is only 2 treatments. You know, she's very, very happy. This is the colleague, the plastic surgeon. After 3 treatments, he went on to have 17, and he have extremely defined, you know, kind of, and youthful facial, you know, kind of like appearance. This is my most interesting case. Like, it's a patient that also her budget did not allow her to have surgery, and I did not know how to do deep plane and subplatysmal work at the time. You know, I gave her the largest amount of energy any Homo sapiens has received with Facetite on the planet. And she had amazing results. Now we say, oh, you have to put around 6 to 8 kilojoules in the face. You know, I put like maybe 18 kilojoules, you know, in her lower face and neck, you know. So it is safe. You know, she had swelling and, you know, bruising, and you can see that she's smiling. I cooked both marginal mandibular nerves. I didn't need to do Botox for her. You know, she had symmetrical smile. And she was very happy. Look at the results 5 months later. So again, you know, really, really happy. I add sometimes Elevate, and the really difficult patients that cannot work without deep neck surgery, you know. So this patient, adamant, I don't want surgery. She needs chin implant or genioplasty, submandibular gland shaving, digastric muscle, you know, kind of like repair, as well as a deep neck and deep face lift to give her a nice results. Yeah, this is how you would go. So it's like a 60,000 pound investment with 6 weeks of difficulty in swallowing. So with a little bit of like Facetite, you know, and Elevate, I managed to get her like really swollen, and she's very happy. I mean, like submandibular glands still show, but it is possible to achieve like transformation of the anatomy if you guide it very well. I have now a new secret. I'm going to launch it: surgical permanent threads that, you know, you can actually lift all the face through tiny little holes in the temple. I will do 10 patients, and then I will tell you about the combination with facelift in next year. So things are emerging all the time. Keep an eye. You know, again, a patient declines to have surgery, ideal for Facetite. She doesn't want Facetite. Okay, let's do Morpheus and a little bit of, you know, Elevate. This is on table. And then I did also her lower blepharoplasty, and you could see great rejuvenation. Just Morpheus, 2 sessions, and Elevate. Yeah, so very nice rejuvenation. Now I think of the entire kind of like superficial, let we call it superficial soft tissue envelope. Like we have the deep superficial, soft tissue envelope, i.e. the SMAS or the platysma and the deep fat compartment, and then the superficial soft tissue envelope, which is just the dermis, the reticular ligament, and the superficial fat compartment. So for that, I want to treat it all. I want to cook it all. So I use, Facetite. I use all the possible depth, millimeter by millimeter, or the tangential planes between the SMAS. I have, Clarius. I can know, what's the thickness to the SMAS, and then I use 3 millimeter, 2 millimeter, 1 millimeter Morpheus. And then we can use also, the Lomecca, the IPL, and a little bit of Morpheus resurface, and you really can have amazing rejuvenation. Wow. Yeah. So again, multi-comorbidities of this patient, and he doesn't want to, or he cannot undergo major surgery. I did an upper blepharoplasty and the local anesthesia with this combination of radiofrequency medicine. I now play with regenerative medicine. Sometimes I put PRP, sometimes I put PRF. Now we have a molecule off the shelf, polynucleotides, that I use it alternative with laser or radiofrequency microneedling. And then we can see really real vector changes and improvement. And I would highly recommend that you engage with objective assessment like that. So in conclusions, I really apologize. I hope that the temperature of the room has not risen enough for you to fall asleep. I want your attention during the clinical demonstration. Skin tightening devices are really promising tools now. The facelift procedure hasn't changed much since 1916 when it was introduced. So we are only 100 years and we have very little improvement. In 20 years of radiofrequency medicine, we have seen 4 evolution of the procedure for skin tightening, and things are moving, now to the muscle. There is now the first device in the world, and I think also InMode have a device that uses different mechanism of action to try and engage the elevator muscles of the face and try to, also include the deeper layers. There must be an evidence-based protocol from anatomical perspective and also from the energy level, etc. It's good that you engage. We have one of the students of Queen Mary University did her dissertation on an evidence-based protocol, and it's published in the Journal of Cosmetic and Laser Medicine. You can refer to it. We have put clearly how many sessions are minimum to be effective, but there is no maximum. You can make it an indefinite treatment plan if the patient is comfortable, and it will still work. You can combine it, and there's need more understanding, so you can help us, as Neil said, with your case reports, with your issues. We have a forum of complication management. Some patients might have some problems, or some clinicians might face questions that they don't know how to solve. We are a group of people who have been working with this platform for several years now, and we will support you, and we will try to find a way together to solve the problem. Very important to manage the patient's expectation and avoid those 23% who might be not sure or unhappy with the results. If you select them correctly, if you apply the right kind of settings, and if you give them a fully informed decision, you will avoid to have that trouble with them. Thank you very much for your attention.